the glycan clock is very relevant to future health outcomes. It tracks general aging. It has known mechanism, and it's responsive to interventions where we've seen it both with caloric restrictions. We've looked at weight loss with 2000 twins, or even bariatric surgery. We've looked at different training types and how they influence it. So we have, and the change cycle is pretty fast. It's a couple of weeks, or we say 6 to 12 weeks. So it's something you can influence in a very short period of time. And you know it has a direct correlation with your future health. And it's things that we already know are good for aging.
Pretty excited about this talk. We're going to try to really dig in and get quite concrete. We have really probably the best possible people we could have to be talking about this, or at least, four of the best people. We gave all the introductions, so I think probably best to just give a preface real quickly. What we want to do in this is really focus on what are the biomarkers that are going to be the most useful right now and in the near future to allow people to actually, affect their health span. So what should they be monitoring, and then what should be done with that? We'll try to cover, it's a lot of space, so we won't cover it all, but we'll try to go through kind of the permutations on that in the next 45 minutes. So the first question is, what really makes a good biomarker, that we can use, that people can actually use to increase their health span. I purposely kind of take out the word aging out of that question a little bit, just because sometimes I feel like some of us go off on a little bit of a side street of saying whether something is definitely aging or not. And so I think really we want to concentrate on what should we be monitoring? What are those biomarkers are for people to actually increase their health span? And that is a very concrete thing, increasing their health span. So who wants to jump in first?
I'll go ahead if you don't mind.
Yeah, I think, Hannah, actually, you had a good kind of set of things. So you're probably the perfect person to do that.
Perfect. Yeah. So very excited to be on this panel. Thank you so much for having me. A couple things that make a good biomarker comes exactly from the American Federation for Aging Research. So they actually gave several criteria for aging biomarkers, and I won't read them verbatim, but I will give you an idea of what those 4 points are. Number one, it must predict the rate of aging, right? So in other words, it would tell you exactly where a person is in their total lifespan. And with this, it definitely must be a predictor of lifespan than chronological age. If you wanted to know someone's chronological age, you can definitely just ask, right? And they should also be associated with a normal aging phenotype or a non-communicable age-related disease independent of that chronological age again. And that's definitely key. Number two, you want to monitor the basic process that underlies the aging process and not essentially the disease. So you don't want to be measuring how the particular aging process affects the disease. You want to actually be able to measure that underlying process. And number three, it must be able to be tested repeatedly without harming the person. So for example, that's definitely one area where this field needs to succeed. We need easily accessible tests that are very user-friendly. And number four, again, not super relatable to our discussion today, but it must be something that works both in humans and then laboratory animals as well. So we need to be able to test this and prove that it's actually working.
Awesome, perfect. Who wants to add on to that or disagree with one of those those four? Not that Hannah's proposing those, but the four that the organization did.
Yeah, I think we agree with all. One that was left out was responsiveness to interventions. So the biomarker also needs to respond to known interventions which benefit health and aging. Sorry, I'm still a little bit unwell today, so you're going to see me brain freeze for a bit.
But thank you for joining us when you're still, hope you feel better soon.
Yeah, and ideally be prognostic to disease or prognostic to health, so you can do something about it on time and not be a marker of disease already.
Awesome. Yeah, it's interesting. So we kind of in practice have started to have this thought, or even looking at it, so there's biomarkers that we find in these longitudinal data sets, and then we're making these kind of predictive models out of them, and obviously we particularly work with Peter on that, and then have some internal models. But then there's the question of, okay, when do we, are there secondary markers really that should come into play where you're saying, okay, like, so we can basically have all our users tracking whether they're fasting or not, but should there be a secondary marker for like, autophagy kicking in, or, are there those secondary things? Because otherwise you kind of see a different thing as the same thing, if you get what I'm saying. Like you're going to say, oh, these people all fasted, but maybe, maybe the different things didn't kick in. So
maybe these people are just going to their fridge more often because they are fasting, looking for food, like secondary markers.
Yes, the movement increases. Yeah, exactly. What's maybe we can expand on that a little bit. Like, should there be, or are we looking for biomarkers that kind of do both?
Well, I think you want biomarkers that are simple that everyone can use, first of all. I'm not sure we're there. You also want biomarkers that you can follow in an actionable time frame, which I think relates a little bit to what you were saying, Michael, this issue about doing something and then following an effect like autophagy. Mm-hmm. I want to add one last thing to feature biomarkers. I think you shouldn't be able to train on them. That is to say, they shouldn't show improvement because you got better at your skill set. They should really be a marker of aging. And I think that can be a bit of a misconception that's out there. But going back to your topic about, should we use surrogate markers? I think that's fine. They often turn out to be markers of health, which may or may not necessarily be markers of lifespan. So I think you want to watch out for that. Of course, most people are very interested in health, which more than lifespan, perhaps. They certainly go together. So I'd be careful about that. But if you really want to do systemic improvement of your lifespan, say across all organs, you really want markers, again, that occur in an actionable time frame that you can follow and that they're easy to perform.
Mm-hmm. Any thoughts on that, Peter?
I would also reinstate that, yes, we need markers that can actually follow the effects of interventions. And what's most important is that the time scale that is required to follow an intervention is also a biomarker of age, as we know. So I think people will learn a lot more from the dynamic properties of these markers and the organism response to those interventions, which means that we need markers that we can actually measure very often without not only killing a person, but also not getting them disengaged. So those markers should be as non-invasive as possible. So that's why I believe a lot in digital biomarkers, which may not be perfect solutions for molecular biologists, although there is a great deal of correlations, as we will find out eventually. But I think that digital trace, even your search history, your online behavior, I'm not talking, of course, about movements and heart rates. These signals, I think, have a tremendous potential because they can be measured without taking us out from our daily routine.
Nice. So I think there's kind of two interesting pieces of that. One, and maybe let's hit that one first. How do we avoid, when we're looking at biomarkers, just seeing some cycle that's happening, some oscillation, if the time period is quite long, say months, how do we not to get into kind of like, data analysis and machine learning terms, but like, on a high level, how do we avoid that?
I think most of those secondary markers which you're discussing are actually very high frequency. I mean, that's almost a definition of a secondary marker. That's something which describes the adaptation of your body state to stresses. Those markers that are related to aging are actually very slow. They are changing slower than in a few weeks in healthy people, and they're very slow when people get sick. So I think eventually we will have a chance to disentangle those reactionary features versus the aging-related features simply by studying the responses at different time scales. We're just in the beginning of this exercise, but once again, as soon as we're getting more continuously measured data on humans, I think eventually we will find out what are the first order and secondary markers of health and aging.
Yeah. Someone want to add on to that? Yeah.
what you can look for is seasonal patterns in data. And I agree, you'll have to, the periods will have to be long enough to see that you're having an extended effect. But it's pretty easy to search for seasonal patterns in data. You have to watch out for all kinds of, patterns that might appear that don't have anything to do with lifespan when you do these sorts of studies.
Peter, it might be interesting, not to lead everybody too much, but I find the idea of resilience that you've started to kind of focus on a bit to be quite interesting. It goes a bit with the kind of the oscillations, but if you can expand upon that for people watching.
Well, I think at least for us, it was a bit of a surprise that, well, everyone knows that when people smoke, the biological age is higher, even if we don't have chronic diseases. What is a bit more remarkable is that when people quit smoking, the biological age in quotes, whatever it means, whether it is DNA methylation age or blood-based age, actually is getting back to the norm. So the biological age does not only describe aging, actually it describes the stress response, the response of your body state to stress. Aging is just one form of natural stress. Smoking is a stress. Depression, stress at work is also a stress. So we know that inflammation markers are going up in such situations. So healthy people get back to the norm very quickly as we age, as chronic diseases set in. The response time, the time that is required to get back to the norm, increases pretty dramatically. So actually in people who are in the terminal stages of their life have biomarkers of age which cannot relax to their norm anymore. So I think that if we start studying not only the levels of biomarkers of age, because the levels could be just a random fact in your biography. You could have a great party a few days ago and you could have biological age a bit, older. I think we should actually look at the response times because they tell you how robust is your organism state, how quickly you can recover. And that correlates a lot with your chances to survive strong shocks like COVID or stroke, for example, with no terrible consequences.
Yeah, super interesting. Hannah, do you see that concept? Because I know you've focused a lot on epigenetics. So there's obviously, you're going to see what sites are turned on and turned off, but what about like the change rate? Is that a concept in epigenetics?
It absolutely is. TruDiagnostic in particular, we measure those 900,000 CpG locations, and epigenetics, don't want to go too far in it, but it's definitely still in its infancy. And it's really important to even measure each CpG, baseline, intervention, 3 months after that intervention, 6 months after that intervention, 12 months after that intervention to measure those very minuscule changes, because even those are extremely important. So the science is slowly but surely getting there. There's just so many different spots and positions to measure. But again, it just goes back to being able to accurately track and what Peter was saying, even have those other biomarkers at those specific time points to indicate what's changing, how is it changing, and what is causing that change.
It might be worth reviewing the different kinds of biomarkers. Traditionally, the initial biomarkers were like simple tests, right? Getting out of a chair, walking 10 feet, coming back in a certain time frame. So you'll see a number of things. Standing on one foot, for how long can you stand on one foot and stay up? So there's a number of things. Those are things anyone can do, and they actually have some value that you can criticize them for a variety of reasons. My own view is the gold standard is the epigenomics that Hannah was talking about, where you follow CpGs. That does seem to be the most accurate, very universal, and does seem to work in a lot of fashions. But there are other things out there. We can argue how valuable they are. PhenoAge from Morgan Levine, if you followed that, she has 9 markers, that most of which you get out of your standard medical exam that you can look at. And I don't think that one works so well for me. I'd probably be dead if it were accurate, because I think I'm off the charts. But it does have some value. It does bring in at least clinically relevant information into this. And then there's other kinds of marker systems as well. Telomeres is the most popular, but I think it's actually the worst. It doesn't, it correlates very poorly with the epigenetics. And I personally am fascinated, Peter's point, with the digital markers. I think that's the future, especially when you're talking about cognitive function and things like that. You you can measure some level of information from a smartwatch for Parkinson's, for example, and other things like that. And I think being able to pull that kind of information in, both for lifespan markers in general, as well as very specific, aging-related disease is the future. And there's a number of companies working in this space. So those are just some of my thoughts about markers in general, and out there. But love to hear people's perspective.
Yeah, and Mike, you were perfectly on time. You're moving to question 2 right on the 15-minute mark. So that was thank you for that. Yeah, so let's open it, keep opening it up there. So what's our favorites? I feel like we're going to have a lot of agreements, and then we're going to have one additional one. But I'll let each person kind of give what biomarkers do you think are the most important coming into the right now and in the very near future?
Yeah, I could go after. Oh, go ahead, Peter.
Oh, thank you. Well, I think that there is always, there is a chance that is important here. So I think with DNA methylation, the timing of that work was so nice that DNA methylation is becoming a de facto standard. So it's convenient, and there is a lot of people working on that. So I think that medical professionals and biologists need to use something that is standard, which is most used, in order to help everyone to establish ground truth. So I think every clinical trial, most of the works have to include DNA methylation now, so that as a community, we gain as much information as possible. We need to have some kind of standard. On top of that, I think there is a fortunate thing. For some people, less surprising, for some people, not so surprising, or a lot of surprising a lot, is that in fact we have a correlation between different biomarkers of age. People that are doing blood markers or DNA methylation markers, if we measure them from the same animal or human in the same time, most of the time we have the residuals, the difference to the mean value to the age, are correlated to each other, which means that there is a lot of common biology that drives the change of different biomarkers of age, which means that we need to focus on those that contain as large piece of that common biology as possible. So, as usual, I'm for the digital markers, but in all the trials that we're trying to run with our partners, we always insist that standard medical tests need to be taken as well, so that we establish those correlations and keep finding better and better markers eventually.
So thank you. And Hannah? Oh, sorry. Let's go to Hannah real quick, and then we'll go to Nina.
Definitely touched on what Michael Snyder stated right before we got onto this question. It's very important to note those biomarkers that are extremely simple, and we're the first of its kind, right? Things like the one-leg balance test, grip strength, different MRI imaging, and this is leading into what I'm going to talk about later on today. There's essentially a new quote unquote third generation clock called Dunedin Pace, which actually accounts for 19 different biomarkers, even things like gum health, right? Your triglycerides, your cholesterol levels are all interworked into this one algorithm, again called Dunedin Pace. So it's more sensitive to change and takes into account all of those original biomarkers, which are still extremely important. So instead of giving you this overarching picture of how you've aged since you were born, it's really telling you how quickly you're aging right now in an instantaneous point of time. How much are you aging biologically for every one chronological year? Which is very important, again, to go off of Nina's point. You need to be able to measure these changes very, very, sensitively over different time points to just be able to track that very accurate.
Cool. Awesome. And yeah, we can talk more about the Dunedin, I grew up in Dunedin, Florida. I forget if the New Zealand one is how it's called, but it's the New Zealand one that has the biobank. But
yes. Awesome.
Nina.
Yeah, so I think here, a lot of times, not on purpose, but glycans are left out because a lot of people don't understand them, not a lot of people research them. But we work with the glycan clock, and it looks at sugars on your immunoglobulin, and they change, they can be good or bad in a way. They suppress or activate inflammation, and the aging theory behind it is inflammaging. And our first publication was actually 2013, same as Horva, but not a lot of labs could used the clock, so it wasn't widely as distributed, but there are more and more comparison studies now which look at both. And the glycan clock is very relevant to future health outcomes. It tracks general aging. It has known mechanism, and it's responsive to interventions where we've seen it both with caloric restrictions. We've looked at weight loss with 2000 twins, or even bariatric surgery. We've looked at different training types and how they influence it. So we have, and the change cycle is pretty fast. It's a couple of weeks, or we say 6 to 12 weeks. So it's something you can influence in a very short period of time, and you know it has a direct correlation with your future health. And it's things that we already know are good for aging and our health.
Well, I might be a little bit controversial, but to me, that's a great health marker. I'm not as sure about it as a lifespan marker. I'm not sure exactly what you're following for glycan, but like glucose, you could argue fasting glucose levels as an aging marker. And it is true, it gradually goes up with age, same with hemoglobin A1C, a marker of steady state glucose. But it's also something that you can, in fact, control through, other kinds of interventions that would probably, directly lower your glucose levels, for example. Now, I don't know enough about the glycan markers you're describing because I am just ignorant on that sort of topic. But I'd be a little careful as to whether that's really a lifespan marker versus a health marker. Doesn't mean it's not important as a health marker. I know it is because I'm type 2 diabetic, so I totally get it. But as a lifespan marker, I'm not as sure. I don't know what others think. I'm stirring up the panel here. yes,
let's stir it up. I guess, but important to say that kind of like Healthspan. I know you're saying that lifespan, but Healthspan. But yes, it is. I guess Nina, is there good kind of understanding of like, is it, if you were just getting your glucose under control, is that going to somehow make the test look that everything's going great, even though maybe functionally you haven't really changed your underlying biology?
So there was a really good comparison study that's still in preprint that compared 11 different multi-omics clocks, including epigenetics and glycans. And glycans, out of all the 9 different data sets they had, glycans came on top with epigenetics in terms of tracking general aging. And we have had other studies where first it replicates in multiple cohorts, and we looked at over 150,000 people from 30 different populations. And it correlated with life expectancy in a certain country, but also the development index of a country. So it caught the socioeconomic influence as well. So it does track general aging, or a mechanism behind it that correlates with health span and lifespan. And it does correlate with a lot of the traditional biomarkers. So when we first, even in the first study, you saw correlation with all the HbA1c, cholesterol, waste, and different clinical biomarkers. And we can explain up to 70% of the variation in GlycanAge from your chronological age to your biological age by looking at those different parameters, but also didn't explain everything. So there was a part that was prognostic. And in this latest study, they were the most prognostic for future incidence of disease and hospital admissions. So it is a general healthy aging marker, I would say.
I'm not sure if you're going to touch on this, Hannah, but I know Dan Belsky has spoken about this in the past, kind of like, how do we avoid, how do we know, like a biomarker needs to, when we're able to change it, needs to say that we're heading in the right direction, right? And so how do we avoid it? It kind of goes along a little bit with what, was just discussed between Mike and Nina, but like, how do we avoid this kind of, we're changing the biomarker, but we're not changing the future? Problem.
Absolutely. I think I'm going to back up one step before that. I think it's important to mention that the idea of methylation markers are so exciting because, again, they are just extremely predictable. So one clock I'll address before that is GlycanAge, right? So the creation of GlycanAge, which a lot of you may be familiar with, is actually trained against 88 plasma proteins. So that's how it was originally created. And it's, after correlating all of the plasma proteins, they were able to pick out 12 of those, which GlycanAge actually predicts. They really cut out all the other proteins if they had a correlation value lower than 0.35. So again, that just shows you, if you're looking to predict proteins, might as well just use that GlycanAge clock as well. And that's the beauty of methylation markers. But to address your question, Michael, about the more specific changes, again, the first generation clocks are more changed to chronological age, so that you can really remove that whole entire generation. Same goes with basically the second generation since the Dunedin PACE has come out. So again, just being able to really track before and after of every intervention at different time points. I like to say you should probably test every 6 months, depending on how accurate you really want to track those changes. But again, the issue goes to it's not super affordable at the moment, and really the best collection method at the moment is blood. So just being able to make that more accurately available, I think, will give people the idea to test more frequently.
Yep. Yeah, and I think well, first I want to give a shout out to Erin McDonald, who wrote that paper that Nina mentioned. I was a student of our chief science officer, and I've spent some time with her, and she's awesome. So it really, what a person to look, to watch in the space. I think just because we're a little bit low on time, maybe just like the last question, kind of open question, we can all jump in, and then we'll kind of, give it to the audience if there's any questions. I guess because we have these different biomarkers, and we have epigenetics, and we have digital, and we have, glycans, how do we, should people be doing multiple of these? How do we see it going forward? Like, is it a blended future, or are we trying to pick a winner here?
Well, I think we're in the early days. I think it's good. I'm a guy who quantifies everything. See, I have 4 smartwatches, so talk about that in a few minutes. But yeah, I think it's early days, quite frankly. And I think all of these could contribute information. We have to understand their strengths and weaknesses. Right after this, I'm going to learn a lot more about glycan markers. It sounds exciting. So I do follow the epigenetics. It does look, I think it looks great. It's been tested now for a while. You can see things that do cause health decline, cancer treatments, things like that, that you can see it does actually shift people's biological age using the epigenetic clock. So it looks very promising in a lot of ways. I wouldn't call it super convenient. It's not a simple, and so I'm a big fan of the digital markers myself, and I have no vested interest here. So I'm not like promoting one of my companies or anything like that. But I just think they're going to be very convenient. I think it's easy to write algorithms around people's activity and heart rate and things like this that all can reflect some aspect of certainly their health state, that's for sure. But I think it'll also reflect their biological age as well. And so I think they're going to be incredibly convenient for people to work with, to operate on. So if you do try, you walk into a drugstore, right? You see a whole shelf of supplements there, or a whole aisle, I mean to say. How do you know if any of those things work? Well, the only way is going to be to measure yourself quite a bit. I think people don't value the importance of biomarkers enough, in my opinion. And so I think we do need good ones. We do need robust ones. And it's probably also the case that there are certain things that, most people are interested in their own particular health span. So if there's certain areas they're high risk for, they'll want to follow those that pick up that aspect the best. So I think you could drill, aside from just systemic biomarkers, I think finding those that drill into your particular area of interest, disease area of interest, will be important in the future. Like Parkinson's, I mentioned earlier. If you're at risk for Parkinson's, you probably want to follow markers related to that. Mm-hmm. So just some of my.
Great, thank you. Anyone else want to jump in on that one? Yeah.
I would say there's definitely markers that should be combined. For example, actually from Erin's studies, it's possible now that skin aging and biological aging, or biological aging of skin and the body, age at a different pace or can age. So I think combining those 2 clocks is interesting. And having the daily biomarkers or the digital biomarkers together with a long-term molecular biomarker, I think is very useful, because if you're actively changing something, you want feedback as soon as possible. And for example, with glycans, we recommend at least waiting 2-3 months. So ideally you would have something in between that you're using to measure daily and get some feedback. So I think combining them is an advantage. Although glycans and epigenetics seem to track general agings, while some of the others track specific risks. So also combining it with specific risk or things that you're concerned of could be a good way to do.
Great.
I would definitely agree with Michael and Nina on that. I definitely think we're too early to say, hey, go 100% with one biomarker. I think it's definitely going to be a collaborative effort, and everyone watching can probably agree, and I'm sure is involved in measuring their own biomarkers in some type of way. And what we all really need to do is come together, gather as much data as possible, really look at every single point that everyone is measuring to be able to come up with those very, very predictive algorithms. And once you have the algorithms, it's essentially a plug and play to see how you are functioning from a particular cellular level, a particular disease condition, whichever condition or disease you may be interested in, which I definitely think is the future, especially with tracking the wearables as well. Getting the wearables involved, I think, is definitely crucial.
Yeah, agreed. And actually, let's do one more question. We can keep going. I think so yeah, Hannah, you touched on it. Like, how do we make these things better? To give some more examples, and you gave a couple. So a couple of things that we're pushing on at Humanity is working with say Illumina to try to sequence out a bunch of more biobank DNA extractions, right? So we can increase the reference set for the epigenetics, and getting the price down, which I don't want to go too fast, but the price is coming down on epigenetics, and so we'll see that soon. And if all of us talk to our connections, it will probably go even faster. What else can we be doing to kind of help the entire space go faster with the biomarkers?
Well, I think we have all agreed that we need to use markers that are predictive of future health or maybe eventually death, which unfortunately limits us to reasonably small data sets. I mean, we have lots of signals, especially in digital space, but our customers either don't die or don't want to report us back if they die, which means that we don't have labels to train our algorithm. So largest biobanks are a few 100,000 people. This is a drop in the ocean of human capital, which means that we really don't know a lot about humans with these small data sets. I think one of the important developments, I mean, it doesn't matter if we are talking about DNA methylation or if we are talking about wearable devices. I think we need to understand better what is, well, I'm a physicist, physics or biology behind the dynamics of those markers. We need to learn how to train those models without labels and validate them on labels. It should be possible. I mean, that's how people in dynamic systems are doing things. If we can do that, we can suddenly look at aging trajectories of, I think, hundreds of millions of people who are digitized right now. And in those large data sets, I think we will find clues to many answers. So basically, my punch is that we should move from models trained on a few labels to really, deep AI on large data sets, really find out what aging is in big data, and then learn how to build biomarkers of that.
Totally in favor of that. I just add one thing on top of that. And then we also need information about interventions. So as people do either lifestyle or, say they do try one of these supplement changes that's in the Walmart aisle there, you want to know if it's working. And I don't think we do a very good job of collecting that kind of information at scale to be able to pull in so-called interventions and see how they might actually shift once you do get these steady biomarkers coming. But I also agree 100% with what Peter just said.
Well, I think nothing beats digital biomarkers here. So that's why they can be used for first-line screening tool that can actually fit hypotheses for more advanced clinical kind of trials. I think it's very important because even a very small app can easily get thousands of people doing some crazy stuff. I mean, we have people self-reporting in our app. They do all kinds of stuff that I cannot publish, but nevertheless, people are interested in their health and they are reporting back what they are doing. Right? So I think we can find a lot of interesting information there.
there are about, probably 10 to 15 interventional trials that have been published to date regarding methylation markers before and after. That's a huge need in this space. People want to know how to change this marker, and they want to know now. They're not just testing to test. They definitely want to test to see a change. One of the good things that we do is we actually work 99%, of our business is with healthcare providers in an integrative and functional medicine space. Being able to work with them, we're getting access to a lot of the covariates that they're collecting from their patients. And we actively have about 26 different clinical trials just looking at before and after effects of methylation markers, using different senolytics, using off-the-shelf supplements from Walmart's, things like, immune modulating peptides and hormone replacement therapy, et cetera. So it's definitely coming. Although, you also want to wait in between tests to see, hey, at what particular time point is this intervention working, and at what dose, and how often, how frequent, et cetera. Great.
Thanks, everyone. And so let's give a few minutes to the audience to ask questions. And then just to say before we go to the audience that we're, a few of us are speaking the rest of the day. So I think you'll get the deep dives. This was the high level starts, and you'll get the deep dives the rest of the day. So yeah, Ali.
So first question is, are there any biomarkers of aging that are recognized by any regulatory bodies?
Not that I know of. for longevity per se. Mm-hmm. For disease areas, yes, but for so-called Healthspan or longevity or aging, whatever you want to call it, I don't think anything's FDA approved.
And but I'm aware. I would add to that as well and say I completely agree. The epigenetic testing in particular is definitely in this weird stage where it's considered a lifestyle test, which again is why we work with providers to be able to give us more data surrounding that. We're still in those de novo FDA pathways, but the idea is we need to define aging as a disease, have a ICD-9, ICD-10 code, be able to then look at particular diseases and then create epigenetic methylation tests that show outcomes of those diseases would definitely be the pathway, hopefully, into that future.
Yeah. So is there something that's approved by regulatory bodies that is for a disease marker, but that can act as a proxy for an aging?
Well, the PhenoAge one from Morgan Levine uses clinical markers that are FDA approved for things. Hemoglobin A1C is one of those. I don't remember them all, but they're pretty much things you get out of a standard, medical visit health check. And so you can take those 9 markers and turn that into an aging clock. As I say, it's even on a website. So if you search, you'll find it. So you can upload your own health information and see what they tell you. As I say, for me, and maybe it reflects my type 2 diabetes, I'm pretty much dead by that measurement. So
go ahead. Sorry.
Maybe I can reflect on that. So I think we should look back in the history of medicine. In fact, we have a biological age already that is FDA approved, and this is the cholesterol measurement. Just to remind everybody, it was found in a biobank as a risk measure that was predicting mortality, which was most probably CVD, cardiovascular mortality back then. So that was the marker, which was associated with the remaining lifespan. So this is the bioage. You could express it in years. I mean, they didn't do it, but I mean, that's just, you can easily fix that. So it was actually recognized by FDA. There were drugs developed to counter that, and they actually extended lifespans. So the whole story worked out exactly in the way we are discussing it right now. So I think what happens is that we're building next generation markers that include more than one factor, that include more factors than just cardiovascular mortality, but ideologically we are on the same route. So I believe that's my personal take on that. I think it's not aging yet. It will be senescence, most probably. There will be maybe some umbrella set of diseases like senescence associated diseases that would be quantified by a marker that looks like a biological age today, and as soon as there will be a first drug approved, maybe everyone will start using markers associated with that drug.
I have a specific question here for glycan markers. Is the glycan markers tissue specific?
So we look at them on blood. That's our main data set, but there is some IgG and some glycans in saliva, but we haven't made a clock or than the methodology for it. And I think the biggest confusion sometimes people think about, because glycans are sugars, so they think about glucose or HbA1c or the sugars we eat and how the body responds to them, but we actually produce sugars. So these are the sugars we produce. And all of the proteins that we've had since we've had multicellular life are glycoproteins. So they're the sugars you produce, and they're in blood, and for us specifically, they're on your IgG.
Okay, and we have one more question. Is there a particular biomarker you would use to track inflammaging?
GlycanAge. That's what it is. Yeah.
Okay, I think that wraps up the questions we have.
CRP levels, I think, is a pretty standard one too. C-reactive protein.
Yeah. So the difference in CRP looks at acute, while glycans and IgG look at this low-grade chronic systemic inflammation, and we look at both this anti-inflammatory and pro-inflammatory ones. So it's a balance, or the homeostasis.
Are there yet any prospective data showing that GlycanAge can predict life expectancy or age-related health outcomes?
Yes, there's a lot. So there's a talk by our chief scientist that's going to be in an hour or two. I'm actually not sure, but I will listen to that, and he'll take you through the last 30 years of research, and we have a lot of data for both.
Awesome. Well, yeah, thank you, everyone. It's been, we just touched on the surface, but I think, yeah, one thing we should all agree on is that we should work together on these things, because I think we're getting quite close, and we're already, I mean, there's already people being healthier because of our different biomarkers. You know, the GlycanAge has customers, and the epigenetics is being done through, you know, Hannah's company, and Humanity has people using both. And Peter has, you know, some great stuff, and Mike has, I know you've been doing stuff in the lab, and you have a few different companies that I think have been using different biomarkers to try to improve people's health. So yeah, it's already happening, and as Peter says, it's happened in the past, and you know, for specific diseases. So I think the hopeful message is that now it's time to scale these things and improve the predictiveness of them. So.